Hi, my name is Debbie, and I am obsessed with all things to do with ultrasound. I'm an empty nester who has spent the last 28 years scanning in all different kinds of situations: clinics, hospitals, point of service, emergency departments, private offices, echo, vascular, general, high-risk OB, and want to dive down deep into all things to do with technology, techniques, and transformation. It's time we take ultrasound to the next level. Think of this like your little power boost on your commute to all things ultrasound, along your way to the thing that we call work. So pull up a seat, make sure you're comfy, and be ready to be challenged and encouraged as we learn it's all about the frequency. Today, we are going to talk with Dawn Park. She launched her career as a cardiac sonographer in Michigan in 2000, following her graduation from the College of West Virginia. While initially focusing on scanning adult patients, she seized the opportunity to learn pediatric echo, discovering her passion for congenital heart disease. In 2009, she transitioned from Children's Hospital, Colorado, as a pediatric and fetal cardiac sonographer. She was also the education coordinator. After 13 years in Colorado, she traded mountains for beaches, enjoying what she calls a very long vacation in Florida. In March of 2024, Dawn joined Nationwide Children's Hospital in Columbus, Ohio, as a pediatric cardiac sonographer educator. She also volunteers with ASE and the Society of Pediatric Echocardiography and the SDMS. Please help me welcome Dawn Park. Thank you, Dawn, for coming and being a part of this podcast. Dawn and I met at the SDMS conference, which I know I've talked about before on other podcasts, especially since it's been kind of recent since I've been there. But like I said, haven't been to SDMS in 5 years for myself. And it really, I feel like, has elevated my desire to go to the next level in my work. After 28 years of being a part of ultrasound, I think having connections and people across the world, or the United States, or the world for that matter, is a great way to network and get to know people and bounce things off of. And so Dawn gave this amazing talk about DeGeorge Syndrome. I wish you all were there, because she's definitely somebody who really knows her stuff, but she showed in a slide how this happens. The syndrome happens in fetal, in the embryology. And all of a sudden, this click just went off in my head. Like, all of a sudden, it's like, oh yeah, like I knew it and I could walk myself through it. But the way she presented it just like made it so easy to understand. So thank you for that. But let's tell me a little bit about yourself and how you got this far and what you're doing and
all the good stuff. Well, thanks for having me. I appreciate you inviting me to the podcast. So yes, we met at SDMS this year. I got into ultrasound. I was looking back in the late 90s. I was looking at what I wanted to do with my life, and I thought it was going to be athletic training. And then I'm from Michigan, and I was at Central Michigan, and my grades were not the best in anatomy and physiology because I wasn't super smart in high school and the beginning of college. It hadn't clicked yet for me.
now, but
Yeah, it did not. It did not click. I remember I had a teacher say one day it'll click, and I thought he was crazy, and it did. But so my grades weren't good enough to get into the athletic training program that was very competitive, and so I came back home, went to community college, repeated A&P, 4-point in those classes. The second time through, something clicked, and I was living with my dad, and I had come home one day and he wasn't there, and I was like, "That's weird." He had gone to the hospital, and he ended up having thoracic outlet syndrome. And he had known the sonographer from years prior and was like, "Hey, my kid's looking for a field. trying to figure something out, like, what is this job like? And so she told him, like, it's patient care, it's physics, which I had done okay in physics actually. Um, and so my dad came home and he's like, you should really think about this. And I was like, well, I want something in the medical field, but I don't know. And he's like, you should really do this. And it's kind of funny because when my dad told me to do something, it was just easier to do it than to fight him on it. And so I was
Right.
like, fine. And so he still takes credit to this day for my career. I went job shadowed. I
So
was
be
like,
it, right?
yeah, right. I job shadowed some people and I was like, this is kind of cool. So I took some classes. I ended up getting accepted because I was a sophomore in college at that point. I got accepted to a place called the College of West Virginia, which was in Beckley, West Virginia. They were a private college that offered a 4-year degree, and I was very adamant on getting my bachelor's degree. And so I was allowed to transfer in, not lose credits, and I still graduated with a bachelor's degree in diagnostic medical sonography within 4 years.
Awesome.
So that school then, after I graduated, changed to Mountain State University, and now it's closed. So the school I went to doesn't exist anymore.
Which makes us feel old. My school's closed too, and it's
Yeah,
like, oh, shoot.
it's how it goes, right? And then I got a job doing my first job out of college because was taught how to do a little bit of everything. And I realized I just like cardiac. And so my first job, I did a little bit of everything. I lasted about 15 months, and a job came available in the town I worked in Kalamazoo that had a children's hospital attached to it, and it was a trauma center. And they said, "Hey, do you want to learn pediatrics?" And I was like, "Oh, sure, it's just like little adults." And I had no idea what was out there with congenital heart disease. And I think the thing that struck me the most was that once I got into it, I had this, oh my goodness moment of what did I miss when I scanned those OB hearts that first year out of school? Because I did a 4-chamber view and that was it.
Oh,
And I was
wow.
terrified as to what I was missed. And so,
Well, yeah, back in the day,
yeah,
like when I learned, I mean, the outflows were new,
yeah,
right?
yeah,
Like it was
yes,
very new. And there
yeah.
were studies done to see if it was even helpful to do the outflows. Remember? I
Yeah.
remember, I can't remember the name of the study now, but I thought now when I look back at it, I'm thinking, how did we even question this? But with technology really taking some leaps forward, it's really, made leaps and bounds in this
Yeah,
field
it's huge.
specifically,
Yeah. And
so
I learned my love for pediatrics and I wanted to do peds full time and they weren't going to let me do that full time. And my arm was hurting from scanning adults. And I was only 6 years into my career and I was like, my arm already hurts. What's going to happen? And it didn't hurt as bad on the days I did pediatrics. And so I traveled for a couple of years. I ended up, when the economy crashed, they really weren't hiring travelers. So my sister lived in Denver and I took a job at Children's Colorado, which is what I consider my echo home for pediatrics. They really taught me and challenged me. I mean, I knew how to take pictures. And what pictures to take, but I didn't know the why behind it. And so I credit Colorado for teaching me learning the why behind it. And back in the day in Michigan, I used to be a scuba instructor. And so that's how I started teaching. And so there I started working with fellows and in the end, I was their education coordinator before I left in 2022. And then took a little bit of a break that I would just want to scan full time, which was not the case once I did it in Florida. And so back in March, we moved to Columbus, Ohio. Little challenging being here because I am a Michigan fan, so it is hard to be surrounded by everyone in Ohio State. But we're getting over it. This is it's been a great I'm an education or a cardiac educator here, and it's just been fantastic. And they're very supportive of my role in teaching. And I just scan still. I scan 3 days a week, and so it's been awesome to be in Ohio, and I'm very happy to be here.
awesome.
Yeah,
Awesome. Great. I love our stories. We all
yeah,
come to it from a different perspective, and so I think it's really helpful to know each other's background
hmm,
and how we come to it, because there's no one right answer and no
right.
one right way to come to it or to do it. So
And I
it's
think also I was gonna say part of it is like I thought Florida was gonna be the final chapter. I really did. And I think it's important in our careers to acknowledge that sometimes you try and it just doesn't work out, and that's okay. I mean, it was a big decision to move to Florida, and it was an even bigger decision to leave Florida. But ultimately, everyone in my family, it wasn't just my decision, it was my family. My parents had moved down there too.
yeah.
And it was a hard decision, but ultimately I was not happy what I like scanning full time, and I was getting injured. And I felt like I missed the teaching. And so we made a decision as a family to find the right job. And I was looking for the right job. I wasn't looking for a place that was going to create the educator job, one that would like that's what I was going into.
Right.
So it's
That's
important
so
to know your
important.
boundaries.
I appreciate you bringing that up because there's so many of us who just, um, I'm a traveler now
Yeah,
and considering sitting down and the same. I want the right job. I don't want just a job, right?
right,
And education's obviously huge to me as well,
right.
And so many of us get out of school from where we went to school and our families are there, so we just stay there.
Hmm.
And you learn so much by going other places, right? And
Right.
knowing how things are done different. And, some of the resistance as a traveler, and you can probably speak to this as
Hmm.
well, is, I'll ask a silly question or what seems to be a silly question to them. Well, there's only one way to measure this. There's only one way to look at this. And I'm thinking in my head, I've done this three different ways,
Yeah, yeah, exactly.
from three different places. And you take an ego hit, right? Because they think you don't know what the hell you're doing. But
Exactly.
in actuality, I know a lot of different ways to do it.
Hmm. I totally agree with that. I think, being in Colorado for 13 years, like they set the bar really, really high. And then going to other places, that really opened my eyes, being like, that's not the only way. That is the right way. There's multiple ways to make things correct and right. And I'm really fortunate to have worked under some really great physicians as well and supportive physicians who helped me realize that as well. Like it's been, the last couple of years have been moving and challenging and all of that, but I've learned so
Right.
much from all the different people.
Yeah, it's just been a wonderful thing to travel, to learn,
Yes.
and SDMS to get
Hmm.
connected, right? And to
Yeah.
get involved, to make a conscious decision to get involved. And how can I contribute? I almost feel like I owe it to people like Ted Whitten and Joy, and
Hmm.
even the instructors that mentored me through my master's degree. Some of them were there, Charlotte Anderson, and I thought I almost owe it to them. I almost
Yeah.
feel like, they invested in me, and
Hmm.
they're investing in my profession still to
Yeah.
this day. And who's going to do it for those coming in and moving
Right.
up to it,
Yeah.
right?
Mhm. I
I
think you
think,
got to give back too. It's,
yeah,
there's so many sonographers who want that mentorship. And it's hard to find. And, being on the Sonographers Do It in the Dark Facebook page, you hear some of these horror stories that people are going through. And I just, wish you could find a way to make things better and know that not every place works the same and not
right,
every team works well together. But it
right.
is important to have those mentors. I think it was last year at SCMS, I had given a talk on it was like you've done a fetal echo and they have congenital heart disease. So now what happens? And it kind of there's not real a lot of research on it. There was very few research articles. And so it was like, what do? You phone your friends, right? And so I kind of put together a list of people from all over the US of what they do on different defects and how often do they scan them. And then I kind of just went over very quick surgical repairs like mortality rates and stuff like that. And one
Yeah,
of the audience participants was like, you've learned so much. And I was like, thank you. And they're like, how did you get like this? And I was like, I thought about it and I was like, it's because of my mentors. They invested in me.
right.
And so
And I
now I
think,
want to invest in others.
right. And I think we're kind of getting away from that a little
We
bit,
are.
right?
Yeah.
And so I hear it from you, I hear it from Ted, I hear it from creator of Echo Mentor
Hmm. Oh,
website.
yeah. Yeah.
Can't remember her name.
Yeah. I met
Um,
them at SCMS. They were fantastic.
yeah, they were
Love them.
fantastic. And I had
Yeah.
her on as a guest. I'll probably have her on again.
Hmm.
And we all have just been talking about we need to still mentor people. And I
Right.
think that is my passion for wanting to do APS, to have that role to be able to mentor, because we can't lose that. Like, I
Yeah.
think that is really a heart and soul of ultrasound, right?
Hmm.
Like, you come out of school, yeah, I can get the picture, but
Yeah.
I
What
don't
does it mean?
understand, right?
Yeah.
And understanding is a huge part of it,
Hmm.
of
Yeah.
investigating it, and
Hmm.
yeah. oh, I think we all can wake up and think, oh man, I scanned that. I can remember specific cases, right? Like an
Hmm.
appendix case, ovarian torsion on an infant. I can remember, all these different cases that I'm like, I just can't find it,
Right.
or whatever. And having that mentor or someone who can come behind you and help you and show you was made all the difference in the world.
Right. Yeah.
So let's get started on DeGeorge, and you
Yeah.
can mentor us on DeGeorge here a little bit.
Yeah, definitely. I've got my slides up here, so I know what we're talking about too.
Yeah.
Um,
So it was an extremely thorough, I feel like thorough presentation because there was so many things that I learned, right? And so even after doing this, for me over 20 years, I'm still learning, right? That's
mhm.
the joy of it. And I thought I really had this syndrome down pretty well. And I'm like, oh, 22q11.2,
Yeah, not 11. Uh-huh. I know. I
not
was like,
11.
I
Interesting.
learned that too.
You know, you're almost embarrassed, but hey, it's okay.
You learn
We
from your
all
mistakes.
are calling it 22q11,
Right. Yeah.
but learning, just those little things that kind of really start to set you apart,
Hmm.
right? So in
Yes.
life coaching, I say it's the small hinges that swing big doors, right?
Yes.
And so I think it's the small details that we learn about things that really kind of start to give us some more credibility that we really know what we're talking about.
Yeah, absolutely. Yep.
Yeah,
Uh,
just walk us through it.
okay. So basically when we talk about DeGeorge syndrome, it's also called 22q deletion is what they talk about. But there are a bunch of different names, catch 22, conotruncal anomaly face syndrome, facial syndrome. There's all these ones, but but what I've heard is a lot of people are trying to get away from the title, and the title is DeGeorge syndrome because it was named after Dr. DeGeorge. And we're trying to get more of what it actually is. So it's 22q deletion, like Down syndrome is 20 trisomy 21.
Right.
And so but it's about happens about 1 in 4,000 children, and they're missing a small part of the chromosome on 22. So yes, I jokingly at SCMS was like, I learned I needed to change the title of my talk to a guide to 22q deletion.
That's right.
So and there's a lot of different other clinical findings that happen in DeGeorge syndrome that I think are important for OB sonographers when you're screening these patients as well. So they have a lot of facial anomalies, like 100% of them can have facial anomalies. Hooded eyes, flat cheeks. They've got a really prominent or bulbous nose and an underdeveloped chin. So these kids, when I see kids who are a little funny looking and they've got like a TED or a truncus, I'm like, I think you might have 22q. Whether or not I've read it in their chart or not, my mind just kind of goes there.
Yeah.
um,
Yeah.
a lot of them, up to 80%, have speech and learning difficulties as well. Hearing loss, vision loss, learning disorder, autism, obsessive compulsive disorder, schizophrenia. It's a whole spectrum. So I think when they're counseling fetal patients, it's really hard to tell like where their kid's going to lie on that spectrum. Another thing they have is neonatal hypocalcemia. So this is where you have low calcium. So there's 4 parathyroid glands in our neck that are going to regulate the levels of calcium and phosphorus in the body. And with 22q deletion, it causes the parathyroid to be smaller than usual and produce too little parathyroid hormones. So this leads to the hypoparathyroidism. And basically, these are going to have low levels of calcium. And why does that matter? The interesting thing is when kids go cardiac or 22q kids go to surgery, they don't have a higher mortality rate because of or complication rate because of the heart defect. It's because of the other things that go along with this syndrome. And one of them is calcium. Calcium is important in our heart. And so it's important for our teams to know before surgery if they have 22q or not. We also have a thymus. So thymus gland dysfunction. The thymus gland is where our T cells, which are part of our white blood cells, they're stored and they help fight infection. And so these kids have small thymus or even no thymus sometimes. It's interesting when I scan a newborn and say they didn't know about a TED or a truncus. and I'm in my parasternal view, so I'm kind of up high, and my images are really bad. Like usually on babies, like soon after they're born, you get pretty decent images.
Yeah.
And they're just images are really, really horrible. And I'm like, we use the thymus as a window almost. We scan through that, and that helps give us good images. And so if they don't have one or it's really, really small, that also makes me think 22q. They have a lot of skeletal anomalies as well. They can have scoliosis, rheumatoid arthritis, club feet, cervical spine anomalies, and they can even have long taper fingers, which is something you like the long fingers you'll see in Marfans as well.
Right. Yeah, I was just thinking that.
Yeah.
Yeah.
Let's see, cleft palate. So palate anomalies. So a lot of them have some type of palate abnormalities. They can have a submucosal palate, so it doesn't look split, but the muscle inside of the soft palate is split. So those ones are a little bit harder to diagnose. And so, cleft palates you guys can see on your OB scans as well. But there's some other ones that are a little harder to see. But one of the things, it's like 30% of those kids will have that. Something called asymmetric crying face. I've not actually seen this on a kid, but it can happen in about 20% of them. It's basically when the baby cries, the mouth is pulled downward on one side. And so it's not a symmetric face when they cry. And then they can have kidney abnormalities. You can have a single kidney, endocrine function abnormalities as well. They can have genital urinary anomalies. It's actually like the male to female ratio is pretty equal. If it is a male baby, they can have undescended testes. And then if a parent has DeGeorge syndrome, they have a 50% chance of passing it on to their child. But only about 10 or 15% of the cases are inherited. It is interesting when you scan a fetal patient and they come in and you're like, oh, it's a TED or a truncus. And then you look at mom, you're like, okay, maybe, she doesn't look like she has 22q. Then dad walks in, you're like, oh, there it is. So
Okay.
and there's
Yeah.
many, we had a case a month or two ago that was coming to us with the new diagnosis of TET. They had done an amnio, baby was 22q, and mom had just got diagnosed with 22q. And so sometimes adults who have very mild symptoms of this, like I talked about, there was a spectrum, they don't know until they have a kid, and then they get tested, and then they find out and they said, yeah, I did have a lot of learning disabilities when I was a kid.
Wow.
So it's really interesting. We do diagnose adults in the fetal lab too with this.
Yeah.
Mhm.
Yeah.
But I think like the biggest takeaway when we see these fetuses, and especially when our physicians counsel, is like no two babies are the same with 22q. Everyone has their own path that they take. And we just kind of follow that path that the kid gives us. So now for the heart stuff, this is all the fun stuff. I did all the other stuff first.
Right.
Then we go to what I really like. So
Well, I think
60,
it's important though that you talk about those things because,
yes,
like long fingers, right? And how easy in ultrasound is, oh, they've got a clenched fist, but I can see, four of the knuckles and the thumb, we're
right,
probably good. And to be able to make sure you're
see
seeing
their
them
hands.
open and close, I mean, I talk about my training that I'm creating for high risk OB called It's All About the Millimeter, right? Because
Oh,
we're looking for millimeter structures that occur in less than 1% of the population,
right.
right? So looking for those things that are subtle, like the chin,
Yeah.
the fingers, the
Hmm.
kidney, when you put it all together and then you go to the heart, right?
Yeah.
It can really start to add up,
Yeah, it
but they're
definitely
very
can.
subtle,
Yes,
very
very, yes.
subtle.
Yep. And I think part of that is also helping us in our diagnosis as well. Like, I see a diagnosis come in, but I still go in with an open mind into all my fetals.
Right.
And but knowing what else they've seen, it's like, okay, yeah, you start looking for certain things. So, but I think like when it comes down to the heart, 60 to 80% of 22q cases have congenital heart disease. It can be, we have TETs, we have TET pulmonary atresia, we can have interrupted arches, truncus arteriosus, VSDs, and then some arch anomalies as well. And so all of this starts talking about these are clonotruncal defects. And so too bad we don't have my little a diagram thing I saw. So I do give credit to Colorado. So Dr. Cesar Gonzalez de Alba, he was one of my cardiologists in Colorado. And I had run a conference and he had done a talk on conal truncal stuff. And when he explained this, it clicked for so many people as well, kind of like, Debbie, you said as well. And so when we talk about these defects, it's all about the embryology. And so basically, you're going to have a tube, and then that tube at the bottom of it is surrounded by muscle. And so that muscle, think of it as a way to support the tube. And what happens is that tube then divides, and it's going to divide into your truncus divides into a right and a left side. And still at the bottom, we have our conus or our infundibulum, which is that muscle helping to support it. So when you look through it and you have like a circular structure of your aorta and you have a circular structure of your pulmonary, around that circular structure is going to be your muscle. And so after the tube fully divides, then what happens is the aortic conus reabsorbs. So that goes away. Okay. So you're left with a pulmonary one. So the aortic conus reabsorbs and then they rotate into a position of where into like your normal position where your pulmonary is to your aorta is posterior to your pulmonary artery and to the right. And so when we get into tetralogy of Fallot and we think about the conus, tetralogy is four things. So we have an overriding aorta and a VSD, pulmonary stenosis, and right ventricular hypertrophy. So when we think about the embryology of this, what happens is basically we have anterior and superior deviation of the conal septum. So what happens is we have the conal septum, which we end up with the hole, the VSD. So basically what happens is that shifts. And basically when the aorta is overriding, it pushes, and that's going to push that conus, and it pushes it to make the right ventricular outflow tract smaller. And then your aorta is overriding because it gets pulled over as well. And so that's how some of these conal truncal defects happen. It's about the embryology. And so because the pulmonary still has a muscle, it still has that conus or infundibula around it, that creates stenosis because now we have like muscle in the way of our outflow. And I always tell people flow equals grow. So if you don't have flow, you're not going to grow. And so that's how you get pulmonary stenosis, because you have less flow going to the arteries.
Yes.
Yes.
And we will definitely link, if it's okay with you, your presentation
The
to
PDF,
show
yeah.
notes. Yeah, because seeing her really dynamic presentation, it just made it all come. And I hope it does for you guys too, who are listening and who want to watch it, because it just helps,
Yeah.
kind of we're this three-dimensional mind of ours,
Right. Yeah. We
It's just
scan in
me.
2D. We got to think in 3D though.
Right. And so when you see it in action,
Yes.
it gives it that three-dimensional look. So yeah, it was really helpful.
Yeah, it was like I said, when he presented that, I was sitting next to one of my mentors, Scott Kirby. He's in Colorado. He's a sonographer there and has echo in his blood. He was taught by his dad back in 1985. And so back in school. And so we just looked at each other and I was like, this is amazing. And here, when I was creating the slides for SDMS, I was talking with some of my coworkers, and all of them say I struggle with understanding the conus. I was like, let me try this on you. And so many light bulbs went off how the conus goes anterior and superior. You have the VSD, it pushes over, it creates it smaller. The aorta comes over. Yeah. You're like, poof, it made sense. So, yeah, it was a really good explanation. Embryology can be tough. It's not my favorite. And that's okay. But as long as I like to keep things simple when I explain it, to hopefully help people understand it a little more and to why it happens.
Right. Yeah. Because when you understand why, then you can, trace things back, right?
Yep. Yeah, absolutely.
Figure it out so much faster,
Yep. And when we talk about TETs, we kind of have the good, the bad, and the ugly. And so you can have pink TETs, which are your good TETs, where you've got a little bit of pulmonary stenosis. You've got the bad ones where you got like a severe pulmonary stenosis or like a TET pulmonary atresia. TET absent pulmonary valve. And then you have the pulmonary atresia with VSD, which is like your most severe form of a TET. But like I had talked about, you have the VSD, overriding aorta, pulmonary stenosis, and then right ventricular hypertrophy as well. The pink TETs, usually we try to repair those around 4 to 6 months. We want them to grow and be babies, be a little bit bigger, and then go in and repair those. And sometimes we can kind of get the kids by and through. We think they're going to be a pink TET, and then they might start having TET spells and where they start desaturating, doing things. And then it's like, okay, we have more obstruction. And sometimes you can actually have obstruction in your right ventricular outflow tract and your pulmonary valve and your main pulmonary artery because it can all get small. So you can have multiple levels of obstruction as well, which is one of the things we look for really closely on postnatal echo.
Different levels of it. Yeah.
Yeah. And then there's the that's like a pink and a blue TET, whether it's mild, moderate, severe stenosis. And then we have TET absent pulmonary valve. So this one's really interesting. So this one, if they don't have a real valve, they don't have like a real pulmonary valve that actually works. You kind of have like two little nubbins of tissue. So you can get a stenosis and a bunch of regurg. And the problem is when that happens, your branch pulmonary arteries dilate up and they are gigantic. And so when these kids are born, they are very, very sick. They have all this compression onto their lungs, basically. We actually lay them flat. We put them prone a lot to help them in those neonatal stages before we can go in and repair them. But they'll get repaired a lot before, much earlier than like a regular TET. But just when they're stable. And then they go through, they do a regular TET repair surgery, whatever they decide to do with the pulmonary, whether it's a transannular patch or RV to PA conduit. And then they plicate those branch pulmonary arteries down to make them smaller because they're too big.
Yeah.
And then like most severe form is pulmonary atresia with a VSD. So that's TET pulmonary atresia is another way to explain it as well. But basically, you have no flow going through that pulmonary. And so you have to have your PDA to be able to supply pulmonary blood flow to your lungs. And so when those kids are born, they're prostaglandin dependent. They have to be on PGEs. And then we repair them quite early on as well. So there's, again, so many different, huge spectrum of TETs.
Right. There is. But another thing that I learned there from another speaker too is, you kind of have to wait. I mean, obviously the severe is pretty straightforward there to know how to support them when they're born. But sometimes you have to wait till they're born and see how they transition, right?
Yes,
To know
that
if
transition is huge.
it's going to be a pink or blue, right? And so yeah, I'm like, well, what's the cutoff? I was asking for specifics, like, is there a specific peak of velocity of, to tell us if it's going to be pink or blue, and the answer is no, we don't know. And, except in extreme severe cases, right?
Yeah. If you're in atresia, we know how it's going to act when you're done. But even like when we look at fetal echo, I don't really care what the velocity is through the valve because your lungs aren't even working. So it doesn't matter. What I'm worried about is what is the Z score? What is the score? What is the measurement of that annulus and the RVOT? And is there a muscle bundle in there that I can see creating an obstruction? Even like with coarctation, like I don't care what the velocity is. I want to know what the measurements are and the arch angles are to be able to help tell.
Okay.
So we don't, like on coarcs, we don't report out our velocity.
Right.
It's the measurements of the arches. It's that Z score. So like a Z score is basically a bell curve almost of measuring what normal is. So 0 is normal, -2 to +2 is normal, and then greater than +2 is dilated, less than -2 is hypoplastic.
Okay.
We use measurements. So that also means we got to get good pictures too.
Right. To get good measurements, right?
Yeah, which is easier said than done some days.
Right. On abnormals, right?
Yes. Yep.
Yeah. And mom's body habitus and mom. Yeah. Yada, yada, yada. So,
yep.
Yeah.
Yes. So, I hear you. But okay, so that was TETs. So truncus arteriosus, these are kind of cool. I love seeing in these. So truncus arteriosus is when our truncal valve doesn't separate into two valves. And so we have a VSD, and then all the flow going out the heart is going out one truncal valve. And then that goes into my aorta, forms into the aorta. And then the branches in the main pulmonary artery come off that artery. And so, when you're doing fetal, it can be hard to, especially if your images aren't super clear, it can be hard to say, is this like pulmonary atresia with VSD because we can't see a second outflow, or is it a truncus? So one thing to know though is if it's a truncus arteriosus, what is usually missing is a PDA. You don't have your ductal arch because the pulmonary arteries come off the main artery. So you don't have a ductal arch. However, there's always an exception to everything, right? So if you have truncus arteriosus with an interrupted aortic arch, you're going to have a ductal arch because you have to have that ductal flow. It's amazing how our bodies just form things or take things away that we don't need. It's amazing how it's formed.
Yeah, we're fearfully and wonderfully made is what I say. Yeah.
Yes. So I think, so truncus, when I'm looking at a truncal valve and I'm really questioning truncus arteriosus, I'm going to look for those PAs coming off that main artery. Also, a lot of times truncal valves are kind of cruddy looking. They're stenotic, they leak. Some are mild, some are severe, but very rarely have I seen like the perfect looking truncal valve. And so that's kind of another little trigger to say it's a truncus. But then if it is, I've got to find those PAs. And we classify it, you can either use Van Praagh or like Collette and Edwards, and we classify it a 1 through 4. And usually on fetal echoes, we'll classify if it's like a 1, 2, 3, or 4. And that just means where the pulmonary arteries are coming off the main artery. So it's just getting in the weeds of it a little bit.
Yeah.
And then I had which you guys will be able to see on there, I had a slide. Basically, when you have a VSD with an overriding great artery, like how to differentiate what it is. And it's like, well, where's the pulmonary artery origin? If the pulmonary artery origin comes from the right ventricle, then you need to talk about the pulmonary artery size. And if it's normal, you just have a VSD. If it's small or moderate, you have a TET pulmonary atresia. If it's super small, like you can't see it, you could have pulmonary atresia VSD. And if it's extremely large, you could have a TET absent pulmonary valve. And if the origin of the pulmonary artery is from the overriding great artery, then you probably have a truncus. And so, yeah, that chart was like, I loved it. It was a great chart.
Yeah, I love that too. I think that's really helpful to be able to differentiate, right?
Right. Yeah, definitely. The next one is interrupted aortic arches. And so these with 22Q go along with the posterior malalignment VSD. So there's the whole ventricular septum, anterior, posterior, apical, mid-muscular, paramembranous, outlet, supercrystal, all these cool names. But if we're scanning posterior in the heart, that's a posterior malaligned VSD. So I've had babies that come into clinic like a couple days old, and they're outpatients, and I put the probe down and I'm sweeping through and I see a posterior malaligned VSD. My next image is the arch. And if I have an interrupted arch, I'm putting the probe down and I am getting my cardiologist involved because this kid needs to get on prostans ASAP. Once I let the cardiologist know they need to start doing their doctor stuff, I'm going to go back and finish my echo, but I'm not going to take 20 minutes or 30 minutes to scan this heart and then let them know. I am going to raise the red flag up and be like, we need PGEs to make sure. So those kids have come into clinic before. And in my career, I have seen babies die from interrupted aortic arches that were undiagnosed. And so when we do our fetal echoes, it's so important to get that aortic arch. So the question I always ask people is what defines an aorta and what defines a pulmonary artery? Pulmonary artery is defined by your branches. Aorta is defined by your head and neck vessels. Yep. Yeah. So we got to see those head and neck vessels. And you want to get that nice candy cane structure looking. And when you have a break in that candy cane, that could be a potential for an interrupted aortic arch. I always tell people, like when I'm scanning and if I see just one vessel heading like straight up to the head and I don't see an arch around, I'm like, oh, that's probably an interrupted arch. I will say it's not a thing I see a lot. And sometimes it's really hard to tell too, especially if you have tough pictures for the flow. So Interrupted arches are definitely important as well. You can see it in the three vessel view where you're kind of missing a segment. In a normal heart, we want the aortic arch and ductal arch to come up and make a V. One of my doctors called it like the flying V, but a section of that is actually missing on an interrupted aortic arch. So you can see it from your three vessel view as well. And then also with DeGeorge or 22Q, there's a couple different types of interrupted aortic arches. We classify them as A, B, and C. And so A is after the left subclavian. The way I remember it is it's A for after. B is between. So B is between the left subclavian and the left carotid. And then C is between the left or the left carotid and the right carotid or the brachiocephalic. And so with DeGeorge syndrome, the most common is type B.
Okay.
Fun fact, AP windows, which I've never seen on a fetal echo, but AP windows, they are most commonly associated with type A interrupted aortic arches. So AP window and A, they go together.
Okay.
Try to do things to make me remember things easier.
Absolutely.
Yeah. And then we talked about vascular rings at the end of it. And so I kind of showed a diagram of a three vessel view. Let me go down to this real quick so I can say it right. So the fetal echo book that I use a lot is a practical guide to fetal echocardiography, normal and abnormal hearts. So it's by Dr. Alfred Abu Hamid. And that book, I love this book. It's so great. So I'm obviously a very visual person because that's what we do. But I like my echo pictures and I like my 2D diagrams and I like them together. And so this book does that. It shows the echo picture and then they change how the diagram is to exactly measure the look identical to the echo picture. And so when we're telling arch-sightedness on a fetal echo, we want to see where the trachea is. If the aortic arch goes to the left of the trachea, we have a left aortic arch. Right. If it goes to the right of the trachea, we have a right aortic arch. And on a normal heart, our ductus and our aorta make a V. But on a right aortic arch, it's going to make a U because the trachea is going to be in between the aortic arch and the ductal arch.
Important, right? That's, one of those things that, this looks normal. No, is it going to the left? I mean, say into your head what you're seeing to verify. Yep, this is a left aortic arch. It's going to the left of the aorta,
Yes.
I mean, on fetal echo, like even in just apical floor chamber, there's a ton of information there, right? There's a lot of things to look at there, right?
Yes.
And so in each view, the three vessel with making sure it goes, there's another list of things to check to see what you're looking at, So, and that's definitely one of them,
And I think it's important. Yeah, vascular rings, they don't have to be repaired right after birth, but the parents just need to know these things. They need to be able to prep for it and know that at some point their kid's going to need surgery.
Right.
Yeah.
Right.
It's
all in being prepared, right?
Yeah. Yeah, absolutely.
I think there's a huge misunderstanding still in the public, with some of the public, that we're just wanting to get this information so you can make a decision on abortion or not. And that is so not our intent, right? No. We're here to support whatever decision our patients make. But if we know ahead of time, man, nowadays we have a whole team of people that is there for the baby's success, and it makes all the difference in the world to know ahead,
Right. Yeah. And I mean, we've had a couple late diagnoses really quick or recently that have really changed, from delivering at a rural hospital to delivering really close to us. And so I think it is important because some of these kids wouldn't have made it if they didn't know. And, nobody loves a late term referral. Like they are hard. You want me to rule out aortic coarctation in a 38-weeker? Okay, I'll try.
Exactly. Right.
But the thing is, you never know. Like sometimes the pictures are great and sometimes they're not. But I think it's important to refer these patients, especially, I mean, like I said, vascular ring's not too big of a deal, but I think sometimes arch anomalies can bring out other things that maybe were missed by the OB team. And
Right.
so it's important to clear the rest of the heart
Right.
because, I mean, you can just have a right aortic arch. If you have a right aortic arch, right duct, it's not a big deal because you don't have a vascular ring. But if you have a right aortic arch, left duct, which left is normal usually, then you have a ring. And if you have a double aortic arch, you're going to have surgery
Yeah.
at some point. And it's important for these families to just kind of be aware of that. And it's just looking at the signs when we're scanning, whether we see a V or a U or a circle. Um,
Yeah.
yeah, but it's not easy. I'm aware of that.
Yeah. But seeing diagrams of it, like
Yes.
you shared with us, it's helpful to see it and then
Hmm.
use that book. I mean, I think that's
Yeah.
been like the Fetal Echo Bible,
Yes.
recently. It's an excellent resource to have if you run into
Yes.
something that you're like,
Yes.
I don't know what this is,
Hmm. Yeah,
these
I've got
diagrams
these two
really
books right
help.
next to my desk.
Yeah.
Because I mean, people come up to me all day and be like, "Hey, have you seen this or what do you think about this?" And I have no shame going, "Let me pull out my book."
Yeah.
I am not
Right.
required to memorize books. That's what they're there for.
Right. Yeah. And so this is what makes our field so unique and so special, right?
Yeah.
And um leaning on people who've had that experience or who have seen that before or can help work that out is just can make all the difference in the world.
Hmm.
I listened to something on Echo Mentor. I'm putting
Hmm.
another plug in for them.
Yes.
Um about how mentorship really helped create a successful result for some patients.
Yes.
When they saw something, the doctor wasn't really sure. She was going to kind of push it off, and another sonographer came in and helped her, and they could really make more of a convincing argument to the
Right.
physician. And
Yes.
the patient went somewhere else and delivered for a really unusual, rare condition, but had a very successful delivery, pregnancy. I think the child is 2 or something now.
Yeah.
And yeah, it does make a difference, to pay
Mhm.
attention to those millimeter structures. So,
And we have here we even we'll back scan each other on hard scans. Like I'll get called, be like, "Hey, can you come up here and take a quick peek? This is what we think it is. Can you help?" Or
right,
sometimes your arm is shot after doing a couple fetal echoes, and you've got BMIs in the 50s and 60s and 70s, and
right,
it's helpful to have somebody come in for 10 minutes and be like, "Okay, I did actually see 2 outflows," or "Yeah, I only still see 1 outflow," because sometimes we can't say prior to birth, this is
right.
exactly a truncus, or this is
Say that
exactly a
again.
pulmonary tears.
Sometimes say that again. You cannot have
You
it figured
cannot,
out
yeah,
before they're born, right?
yeah, it's okay. But what it's important to do is to describe what you see. We see 4 chambers, we see 2 chambers, we see 1 outflow. And so
Right,
the studies that are really hard, we don't get into the weeds about what it is. We get specific about what we can see and what we can't see and what we think it could potentially be. But the biggest question we have to tell people is it prostaglandin dependent or not? Does this
right,
kid need PGEs for pulmonary circulation when they are born or not? And
right.
that's what we tell them. And sometimes
Yeah,
we get it
which is
wrong,
pivotal.
but we try not to.
Right. Well, it's a human, this is where if we don't see it, they don't see it,
Right.
right?
Yeah.
It's very dependent on
Hmm.
our skills and our knowledge.
Right.
And so that's why it's so important to continue your education and continue listening to things like this and
Yes.
expand and go to seminars. And
Hmm.
I love it that we get to still learn all the time, every
Yes.
day,
Yeah. Yeah.
Um,
I like going to the conferences. I really like, I started presenting for SCMS a couple of years ago. One of my friends got me introduced to it. So back in like 2016, 2017, I started to run the pediatric echo review for Colorado. And I met someone who's a very good friend of mine now. And she was like, "Why are you and Scott like hiding in Colorado? You need to be out there doing more." And so
yeah,
she kind of lit the fire to start doing some more out there on a more national level. When I went to SCMS for the first time, I was like, I love this. Like, I think ACE is great. I help them with stuff. I volunteer for them. I go to the scientific sessions. But the difference of SCMS is it's sonographer focused. It's like the grassroots, it's the foundations of it, which really excite me when I'm there to talk to people.
Yeah, and so much of the time, I think there's in my past experience, I thought, oh, it's just for beginners
Right.
and students and, people just coming out of school
Right.
and blah blah blah. And that's just not the case.
No. Mm-mm.
I talked to a man who does very good jobs of TCDs in the heads, and I remember doing those for a very short period of time. Um, and he zoned in. That was his specialty, right? Or one of them. And to be able to have the nuggets that he gave for that kind of an exam could change your practice, right?
Yeah.
And really, I'm like, man, he makes me feel like, oh, this is, I didn't care for the exam, but after listening to his, I'm like, oh, well, maybe I could be a little bit more interested, or
Yeah.
maybe I could, you know, take his skills and what he had shared and take them back to my practice and become better at it,
Right.
right? And so it's not just for beginners,
Right.
it's not just for first time students or things like that. And I think as our profession goes to more of the advanced practice
Mm-hmm.
circuit, I think we'll even have a lot more research that's being done
Mm-hmm.
and more things that sonographers are really putting out into the world.
Right.
So
Definitely. Yeah. Yeah. It can be, sonographers can do a lot, and it's important for them to have the right mentors to help. Like I'm writing up a case study right now, and I, writing research and case studies is not my forte, and I'm okay with that. But I have a great physician mentor, and in the past, I've had great physician mentors help me through it. To be able to get my name out there and be first author and be very supportive, but also teach me. And so, I know the basics
yeah,
of some
and
of this
you
stuff.
might learn how to do it and then do it a couple more times and
Hmm.
then you're proficient. You're like, oh, well, this isn't near as hard. And then
Right.
I might like this a little bit
Yep.
more, or,
Hmm. Yeah.
that's how we grow, right? We don't
Yep.
like it the first time we do it, right? We never do,
Hard.
right? And but we get there.
Yes.
We get to learn to like it or we see the benefits of doing it, so then we enjoy
Mhm.
it more
Yeah.
or whatever. So, yeah, I think all this is super important. So thank you for sharing your knowledge and your
Yes.
beautiful slideshow. And definitely we'll invite you back to have more conversations about other topics. I think it's important that OB, high risk OB people talk with fetal or
Mhm.
pediatric echo, right?
Yes.
Because
Absolutely.
we cross our specialties so much, right?
Yes.
And we can learn from so much from each other, I
Mhm.
think, um, that it's important to have someone that kind of in your back pocket, like, okay, here's a picture. I'm sending it to Dawn. Hey, Dawn, take a look at this. Can you help me?
Oh, I've got those
I,
people that call me.
yeah,
They've got me on
yeah. I
speed
used to
dial
do
that.
that with a cardiologist I worked for. It's
Uh-huh.
like, oh, here,
Hmm.
I'm scanning somebody and I
What do
just
you
snip a
think?
quick picture. Okay,
Yep.
this is what I've got. Are you coming or should I?
I even have one girl, she's learned. She used to send me some clips, like still images. I was like, I need some videos. I do
Yeah,
not do still
yeah,
clips.
video.
I do videos. And so
Right.
like they do that. And even here we have two MFM sonographers that perform some of our fetal echoes, just because that we're building a fetal care center here. And so we don't have enough OB exams to keep them busy full time. And so our fetal echo volumes are pretty high. And so the pediatric cardiac sonographers are still scanning, but they're doing the MFM sonographers. We train them in fetal echo as well. And
Right.
so when they have a really complicated case or they're not sure, we walk upstairs or take the
Yeah.
elevator, one of the two. But we come right up to help out and get some pictures. And there's,
Right.
4 or 5 or 6 of us that can come up there and help. And so I
Yeah.
think there's no shame in my game to say, I need somebody to help me take some pictures.
Right.
And I'm not going to hurt myself to get these pictures. And even if they are easy pictures, I just want another hand on the probe to help out. And I think that's important that we all are humble. Um,
Absolutely.
yeah, that's a big part of us being humble when we
Yeah.
find these things and know that we
Always.
can, yeah,
Always.
Yeah. I'm like,
Otherwise,
I'll
this
take help
field will humble you very quickly, right?
very quickly. Yes. Very quickly. Yes. Yes. Yes.
Well,
So,
thank you, thank you, thank you. We appreciate your time. I know you're super busy, and thank you for giving back to our profession. And we will talk to you again on another podcast soon.
all right. Great. Thank you so much.
You're welcome.
All right. Have a good day.
Thank you for tuning in to It's All About the Frequency podcast. I hope you enjoyed today's episode. Share it with a friend, and remember to keep your frequency high.